Okay, hello everyone. Thanks for taking the time to join us with today's webinar. This is Amy, and for today we'll have a webinar lectured by our speaker, Dr. Suhaib. And for today's webinar, it will take around 45 minutes to 1 hour. If you have any questions, you can write in the comment section. The speaker will answer the question for you, or you can direct message to us or to the speaker. So let's get started and welcome the speaker, Dr. Suhaib. Thank you.
Hello, everyone, and thank you, Amy, for making this webinar happen. My name is Dr. 𝗀𝗂𝗶𝗰, and today's topic about your guide for safe instrumentation. Thank you, everyone, for being here to watch this webinar. Well, my name is Dr. 𝗀𝗂𝗶𝗰. I'm from Amman, Jordan. I am a member of the Jordanian Society of Endodontics. I am a KOL of Fanta company and KOL of 𝗀MC Jordanian Microscopic Company. I took a part in many courses here in Amman, Jordan, in root canal treatment. I work in 2 clinics here in Amman, and I was honored to have the first Fanta dental microscope in 2022. And then the other clinic with Dr. Samer Mabrouk also bought the same Fanta dental microscope. Well, first things first, have a safe flight. Always when you go on a plane, your captain say have a safe flight. What does the captain mean by saying have a safe flight? Having a safe flight means that you will reach your destination without losing any of the passengers and with the minimal stress. Same as for root canal treatment. In root canal treatment, you must reach your destination without losing, having any broken instrument, zipping, transportation, or perforation. And how could the pilot did this? By following a standard protocol. Same as root canal treatment. You have to follow a standard protocol to reach your apex. The captain will not start figuring out or start looking for new tracks to reach his destination or try new destination or airports. This is not okay. In root canal treatment, the same thing. You have to follow a standard protocol to reach your apex with the very minimum stress and very minimum complication. How can we do this? We can do this firstly by the preoperative. Whatever preoperative assessment, preoperative preparation. Preoperative assessment. How can we do and make a preoperative assessment? We can start by the case assessment. If you are a referral clinic or if you are a normal dental clinic, usually you will have a preoperative X-ray, 2D or preoperative CBCT, or even if your colleague send you the case, he will send you a report with it. You have to sit down in your clinic and watch the X-ray carefully, looking for broken instruments, looking for perforations, looking for curves in the canal, assessment the caries in the tooth, and thinking backward. Thinking, is this tooth is restorable? Let's think from the prosthodontically before endodontically. Can we save the tooth? Okay, we can make a root canal treatment, but can we save it? This is very important. You have to take your time reading the preoperative X-ray. And also this will help you in preparation. Good preparation means success. Without preparation, there is no success. How to prepare for your case? Well, by the armamentaria, instruments, tool, devices. For example, you have a huge periapical infection, You may intracanal medication. Do we have intracanal medication? We have a broken instrument. We need a lot of manual files. Do we have a manual files? We need a lot of manual files. Do we have? We need to retrieve the broken instrument, for example, micro tweezer, PFR pen. Do we have PFR pen? Do we have micro tweezer? Always prepare for your case by the proper instruments, tools, magnification, whether loops or, of course, microscope. And the most important part is to educate your patient. Yesterday, I was in a training course, and they mentioned educating the patient by motivational for the patient. Is it the same, motivation the patient, or educate the patient by giving him a micro lecture why you want to do a root canal treatment for his tooth? What is going inside his tooth, and how many appointments do we need to do the root canal treatment? Do we need like one visit, single visit, 45 minutes, 60 minutes? Do we need two visits? Do we need three visits? Always educate your patient how that is going to be helpful for us. First of all, you will gain your trust with your patient. And second thing, that you will do your treatment with the minimal stress, because the patient already know that this appointment will take 1 hour or 3 visits. But if you tell him that you need more than one visit after the initial visit, he will be surprised. Like you did something in complication, you did something wrong. That's why you want to give me more than one visit. And also to put the appointment in the patient schedule if he is traveling, if he have some things other to do. Okay, so after the preoperative assessment, preoperative preparation, this is a very important part from point of view. As you can see here in clinical assessment, on this X-ray on the left side, we have a huge periapical abs infection related to the upper lateral. Is it restorable? Does he need absectomy? Can we finish it in a single visit? Well, you have to discuss this with your patient. And on the right side, you can see there is a broken instrument in the mesiobuccal canal. Can we do it in single visit? Is 60 minutes is fair enough to do the full treatment or no? This is a very important things to give the best treatment to your patient with minimal stress. And something else in preparing for the cases, magnification. Microscope is not a luxurious anymore. It's an essential thing to do in root canal treatment. Check the first photo on the left side. This is upper right 7 without any magnification. What can you see? You can see nothing. You can't see anything with your naked eyes. Okay, and then we go to the first step of the microscope. And these photos, by the way, have been taken by the Fanta dental microscope through a phone adapter to the microscope. You can see it very clearly. The anatomy, everything is very clear. The first, the middle photo is Fanta microscope with 3.2 magnification. It's fair enough. It's same as loops. The loops you can see as this magnification, 3.2. On the right side, this is a 0.5x magnification. You can see much better. On the first photo, this is with microscope 8 times. In the middle is 12.5 times. And the last picture with 20x times. You check the huge difference between the first photo here and check this picture here on the right side. Without seeing properly, there is no proper treatment. The whole idea of the root canal treatment is to find all the canals, clean all the canals, and fill all the canals. How can we do this? By the first photo. You can't see nothing. But with this photo on the right side with the microscope 20 times, amazing. You can treat it very stressfully, with a minimum stress and very clearly. And the Fanta dental microscope, by the way, have 5 steps in magnification. Okay. Access. After the preoperative assessment and preoperative preparation, let's start with the root canal treatment. First of all, you want to do an access. As you can see here on the photos here, we must do a straight line access. Straight line access doesn't mean that you have to be very big cavity or big access. You want to do a proper access so you can do negotiation and finding all the canals without being very invasive. Here, as you can see in all the photos, we are doing under microscope very adequate, proper access. We can find all the canals, 4 canals, 3 canals, 2 canals, with a proper straight line access. As you can see, straight line access is very important. Why? On the first photo, first X-ray on the left side, this is the straight line access. Straight line access will give a very minimal stress on your files. Other than that, you will have tactile sensation about what is going inside the root canal anatomy, not having a sensation of the coronal part of the tooth. No, you are having a tactile sensation, feeling what is going inside the canal with minimum stress on the file, with the safe stress on the file. As you can see on the third photo, X-ray on the right side, this is not a straight line access. This is not safe to your files. This will cause a lot of stress on your files, which will lead to broken files, which will lead to ledges and other complication. So we want to take our time in making a straight line access to have a proper obturation, as you can see in the middle picture. Okay. In my routine cases, I start the access with the long shank diamond burr. Why do I use a long shank diamond burr? First of all, I use a long shank so can the tip or the head of the handpiece won't block the vision on my work. If you have a short shank, the head of the handpiece will block the vision for you. You can't see. So it's impossible to have a proper access with a short shank. So always go with a long shank. And why I use a diamond, so I can have a flaring for the canal, for the coronal part of the tooth. And also I love to flatten the cusp if it's going to have a crown after the root canal treatment. Why? Because I can have a stable working length. You cannot always rely on the dental, on the cusp of the tooth to have a stable working length. Why? Because it's going to be different from different angle. For example, if you are looking from the microscope and you change the angle of the microscope, the working length will be changed because you change the angle. So have a flat cusp will give you a stable working length. This is very important. And how can we have a flattened cusp? There is a lot of pairs, but in my dental, in my practice, I use the long shank diamond pair. Long shank diamond pair is amazing for doing this. And this is cutting end. I use a cutting end because I work under magnification, so I see clearly what I am doing. And after having a straight line axis with a long shank diamond pair, I go to remove all the pulp tissue with the sonic activation, as you see on the right video. Why we use a sonic activation is very minimally invasive, very conservative on the pulp floor. And other than, you must know that the sonic activation there is a huge difference between the sonic activation on your dental chair and there is a specific devices for the sonic activation. The sonic devices on your dental chair is not accurate as the intensity you want it. But on the devices made especially for the sonic activation is very accurate intensity. There's many devices you can buy with the sonic activation and different tip. As you can see here in the video, we can remove the pulp and the champers, the pulp horns, and finding all the canals also through the sonic activation. So it's important to start your access with the also sonic activation, so you can find all the canals. You can't do irrigation now because there's no orifice or canals to irrigate it. You only wash out the floor of the tooth. Access and working length determination. You can start having estimated working length by pre-operative X-ray. You must have a pre-operative X-ray device and a proper and good sensor. Do not rely on an old sensor you have. You must have a new sensor, a new X-ray to have a beautiful X-ray. You can read it and have estimated working length before starting. Why do I want estimated working length? I wanted to know what files do I need. 21 manual K files, 25 manual K files, or even 31 manual K files. Here in this case, upper 4, we used 20 manual K files 21. The first manual, always start with the manual K files to explore your canal and feeling what is going inside the canal. After having an working length by the apex locator, always start with the apex locator because it's more accurate than the preoperative, more than accurate than the periapical X-ray. Well, check the first photo on your left side. This is the same tooth. On the first one, the apex locator will lead you to the anatomical apex, while the other photo on the same other file on the same photo is give you a radiographic apex. There is a huge difference. In the first one, apex locator will give you accurate working length, while the periapical X-ray will give you a radiographic apex. If you are going to work routinely on the radiographic apex, you will have so much post-operative pain over instrumentation and may lead to overfilling. You doesn't want this to happen. But you can check on this video. As you can see, the apex locator will give you 0, 0. What mean by 0, 0? You mean you reach your anatomical apex. This working length, you must respect it so much and keep having another reading through the whole procedure to stay on the same working length, because sometimes you start working length, for example 21 millimeter, but in the middle of the case, after the canals become perpendicular and more straight, you will have like 20 millimeter. This 1 millimeter or 0.5 millimeter, if you don't take care of it, it will make a patient suffer post-operatively. So let's go back. As you can see here, we took the working length by the apex locator and then confirm it with the periapical X-ray. If you took a periapical X-ray The apex locator said 0, 0, and the periapical X-ray said 0. Was shorter 1 or up to 2 millimeter. It's okay. Trust your apex locator. Do not trust your X-ray. We took another X-ray with the rotary files to check the working length. Are we still in the same working length? This is very important to minimize the post-operative pain for your patient. Always start your negotiation with stainless steel files. Stainless steel files are made to reach the working length, while the nitrile files made to shape this working length. A huge difference. Manual files to find the working length, rotary files is to prepare and shape the working length you had. Of course, manual K-files will give you tactile sensation. Nitrile rotary doesn't differentiate between ledge, calcification, perforation. It just drill inside, it's just rotate inside the canal. While the manual files in your hand with expert, you will start feeling and having an tactile sensation. What is going inside? Are we inside the canal? Are we inside perforation? You will start feeling this with the manual files, not the rotary files. So always start with a manual files, manual K files. I start with the manual K files, not the C files, because C files are more aggressive, cutting tip, and more stiffer. I use it in other cases, but in routinely cases, I use manual files. You have manual K21, 25 to 31, as we said. So you have access, you have the apex locator, you reach your apex safely. And now let's start with the cleaning and shaping. Always start with coronal flaring. Back in the time, they used to do coronal flaring with the 𝗀𝗬𝗂𝗿. For me, I never used 𝗀𝗬𝗂𝗿, never ever. I always use rotary files. Okay, a glide path. After doing a coronal flaring, you will have a glide path. This is on the photo on the right side. Always, when you want to start your negotiation in the canals, do a pre-curve or pre-bend to the manual files, because it's very rare to have a straight apical foramen in the teeth. So always have a slight pre-curve in any vital case. It will lead you to the apical foramen. Pre-bend is for other cases like ledge, for example, or very curved apical foramen. Fanta rising rotary files have a R1 file, which is 13-3, to have a very smooth glide path. You don't have to waste your time using manual files, 10, 15, 20, to have a smooth glide path. They did a R1 file, which is 13-3. It will give you a very smooth glide path, very smooth, quick, and amazing glide path. And this will make your case very quickly. Instead of keep negotiation with the manual file. Of course, after reaching your apex by the manual file, you will use the R1 file. Okay, for cleaning and shaping, my cases recently was done by rising rotary file from Fanta company. They gave me samples in Dubai, EDIC 2026. After Dr. Muhannad Takruri, my dear friend, introduced me to the Fanta company in the Dubai, we met and they gave me this rising rotary file to try it. And I was amazed by the amazing results that you will see. This files have 5 assorted files, starting with the RR17 with taper 10. This is like the SX or the open file. And this, you will use this file instead of 𝗀𝗬𝗿𝗀𝗃. After, you will start with R113 for glide path. Then you can finish R2, which is 25 per taper, or R3 or R4 as you want. You can finish, for example, MB2 with R2 25 taper 4. The recommendation by the company is to use the speed 450 revolutions per minute with the torque 2.5 nanocentimeter. Well, in this case, I will present for you upper 4 for all patients with a crown on the tooth. We couldn't remove the bridge because it's a long span bridge. As you can see, if you can read the X-ray carefully, there is a metamorphosis calcification on the canals of this tooth. And there is a porcelain fused to metal crown, which make the case more complicated. In this case, there's something I want to say. Do not treat all the cases by generalization. Every case is unique. Not every case is generalized. There is no generalization in root canal treatment. You must give every case a unique treatment. For example, I mentioned to use always long shank diamond pair. In this case, we have a porcelain fused to metal crown, so I will use short shank in the beginning to cut through the crown. As you can see, I'm using short shank. Then as I mentioned before, the head of the handpiece will block the vision for you. But if you use a long shank, now I will use the long shank. It's much better now. You can see. Okay, we did a straight line access through the porcelain fused to metal crown, and you can see how much is calcified. You can see how much it's important to use the microscope in these cases. I won't do any perforations. I won't do over preparing or over drilling in the orifice. I just did a very minimal just to find the canals. And until here, I didn't find it. I will start looking with the sonic tip, as we mentioned. I'm using the sonic tip with the special device for the sonic activation. I stopped using the drilling. I keep checking with a very sharp probe, and thanks God we find the 2 orifices for the upper 4. It's very calcified canal. In this case, we will use rising rotary files from Fanta. Of course, you want every root canal case, we must mention that you must do it under rubber dam isolation, whatever, single or multiple root canal, multiple rubber dam isolation. These things like rubber dam isolation, magnification, these things, it's important in root canal treatment. It's essential, not luxurious or for documentation. It's the key to success in any root canal treatment. As you can see, we start negotiation with the manual K files from Fanta, 21 files. We did, as you can see, pre-curve for the file. It's work like an antenna, looking for the apical foramen. Where is it? And you will feel it. If your case need more than 1 file to reach the apex, then it's not a simple case, it's advanced case. But if you need only 1 file to reach your apex, then this is a simple case. Other than that, if you need more than 1 manual files to reach your apex, this is advanced case. So you must take care and be careful in using the files to reach the apex safely. As you can see, we start negotiation. We have estimated working length. As you can see here, we reach the apex with the X-ray and the apex locator. Now we will start with the RR file. RR file from Rising Fanta company. RR files is used, is a 17 with the taper 10 to flare and flare the orifice for you. An important tip while using the rotary files. As you can see here, I just did a single stroke and clean. This is a way for the professor, for the Dr. Alain Ali Nasser. He always say, do a SSC, single stroke and clean. You can't, if you have a spoon of sugar, you can't take another spoon while another spoon of sugar while the spoon is still full of sugar. You have to take out the sugar from the spoon and go and take another spoon of the sugar. The same as for rotary files. If there is a flutes and debris between the flutes, you must clean your flutes immediately and then go back. Otherwise, you will start having some difficulty in the root canal cleaning and shaping. So always check your debris on the rotary files, clean it before entering another time. So let's work on the single stroke and clean. And by the way, Fanta Rising rotary files, recommendation is to do a crown down technique, not step back technique. Of course, a crown down technique will cause less debris outcome from the apex, so less pain. As you can see, the flaring from the RR file. After flaring RR file, I'm using a sonic tip to irrigate and remove the debris. I didn't use irrigation until now. I'm just starting with the sonic, because sonic activation or ultrasonic activation is the best way to remove the debris. As you can see, I did with the R13, the glide path, the amazing glide path. If you noticed on the first X-ray, the preoperative X-ray, the canal was very calcified. But with the help of the R13, check how smooth it is. Always remove the debris from the flutes, single stroke and clean, single stroke and clean. Again, I'm using the sonic tip. Why I'm using the sonic tip? Because sonic tip will remove the debris for you. Now, after R1, now I'm using the R2, which is 25 taper 4. Always check what is going from the tooth. Is it pulp tissues? Is it debris? Is it pus? Now I can irrigate the canal starting with sided open needle, sided vented needle with the sodium hypochlorite, full concentration. Now I'm going to the R3, 30 taper 4. Amazing files. Irrigation again with the sodium hypochlorite with full concentration, 5.25. And keep, there's an important tip if you want to do a safe instrumentation. Once the needle is stuck inside the canal, do not push the irrigation. It will lead to a sodium hypochlorite accident. Always move freely inside the canal, up and down. So you must always have a thinner gauge of the needles. Now I'm finishing at R4, which is 28 taper 5. You see how the case was very smooth using the Rising rotary files. And this is the, you can see we have two orifices, very clean, very conservative. Irrigation, I think now we are irrigation with the Edita irrigation, so we can remove all the smear layer that accumulated in the dentine. Of course, we will use Ultra X to activate the irrigation inside the canal to reach all the biofilm inside the canals. It's impossible to touch all the canals with your rotary files. It's impossible. How can we clean all the walls of the canal? By using irrigation, sided vented needles, sodium hypochlorite, EDTA, and Ultra X activation to remove all the biofilm. If you still have biofilm in the apical area, the patient will suffer. And the companies nowadays, they are putting more zirconium in the obturation material, so you can have white lines. And white line doesn't mean that you have a success. As long as you have a biofilm inside the canal, despite the white lines on the X-ray, you still have bacteria inside the canal. So how we can get rid of the biofilm inside the canal? By sided vented needle, good irrigation, sodium hypochlorite, good irrigation, EDTA, and activation of the irrigation, not only the rotary files. Keep cleaning with the sodium EDTA. And now I'm going to dry the canals with a paper point. And now placing my resin-based sealer, 2 canals. I will take an X-ray with the sealer with it. You can see how very minimal and very conservative treatment for this tooth. And now I'm using the fast fill. I'm also Fanta company, doing condensation, so all the voids and all the sealer come out. We want to fill it with the 𝗬𝗂𝗶𝗃. It's a 𝗬𝗂𝗶𝗃 based obturation, not sealer based obturation like bioceramic sealer, for example. Bioceramic sealer is a sealer based obturation, but in this case we used 𝗬𝗂𝗶𝗃 with the resin-based sealer, so it's a 𝗬𝗂𝗶𝗃-based obturation. So we rely on the 𝗬𝗂𝗶𝗃. Now using the fast pack, condense every layer gently, and now you can see how beautiful the case is. Very clean and beautiful, well-filled 2 canals of the upper 4. The resin must be removed with the cotton pellet or a small brush with alcohol. Not like the bioceramic sealer, which is you can wash it with the water, but in this case you have to remove it with the alcohol. Why? If you left any kind of the resin sealer inside your orifice, it will lead to composite failure, and this is very bad. So you have to clean it carefully with the alcohol. And another thing, you must have this orifice look like this in any teeth, especially anterior teeth. Other than that, the patient will have very discolored tooth in a very quick time. So clean your orifice and have this beautiful orifice. After this, we're placing an acid etch for 20 seconds, then wash it without dryness from the syringe with a cotton pellet. After that, we change the filter of the microscope, of course. We change the filter of the microscope to orange microscope. This is specific for the composite, so you won't have a premature setting of the bond and the composite. We put the first layer, then we place the second layer of bond, first layer of bond, then we put air on it, then we put the second layer, then we put again air on it, then we cure it. And this step from my friend Dr. Sinan Ghishan, followed by Dr. Louis Hardan. And it's amazing to have a very strength bond. Light cure, then putting some layer of the flowable composite light cure again, putting another layer of flowable composite cure again, and then putting a composite. Amazing. This is the final result of the obturation. We stick to the working length. We reach the apex safely without having any broken instruments, without having any ledge, any zipping, any transportation. This is first X-ray on the right side, upper right side, preoperatively. You can see how much it was calcified, especially coronally, and this on the left side, the final results. Okay, and this is how we did full cleaning and shaping. Let's talk about cyclic fatigue, torsional fatigue in your rotary files. Everyone know this video from the YouTube is very famous video talking about cyclic fatigue and torsional fatigue. The cyclic fatigue, it's while the file is running freely in the canal, but is having a very stress and compression all the time, without stuck inside the canal, which will lead eventually to a fracture. You see, stress, compression, stress, it will lead eventually to a fracture without binding inside the canal. This is cyclic fatigue. This is when you use the files so many times, when you sterilize it so many times. But why you want to do this? You have a Fanta company, for example, the files are very affordable. You can have a rotary files for every patient. To be honest, in my practice daily, sometimes I use more than one kit in the same patient. Why to have this cyclic fatigue and broken instrument? Why to do this? Stay away by always using a new rotary files, and for the manual files, it's already done. Do not use it more than one time. Do not put it in the sterilization. Your finish is disposable files. Get rid of it. On the right video, this is the torsional fatigues. When the tip of the file gets stuck inside the canal while the file keep rotating, you will end up having this broken instrument. How can we avoid the cyclic fatigue and the torsional fatigue? We can avoid it, the cyclic fatigue, by keep using new files. Do not put so much stress on your rotary files. It's affordable now. You can buy many of rotary files, not like the old times. And how we get rid by the torsional fracture? By having a very smooth glide path all the way to the apex. After we talk about the preparation, access, working length determination, cleaning and shaping, and full obturation, now let's talk about the post-operative pain. The post-operative pain happens for mainly three reasons. First one is the debris control. Second cause is the irrigation control. And the third one is the instrument control. And there is another reason, which is the sealer itself. Debris control, which is the biological factor. Anytime you go beyond the apex, in any case, you will end up having a post-operative pain. Anytime. So you must be careful during taking your working length determination, as we mentioned before, by flattening your cusp, by taking by the apex locator and confirm it with the X-ray and keep routinely taking your working length again and again. So in this way, you will have minimal debris extrusion from the apex. Another thing is it's been shown that the crown down technique is less to have debris extrusion from the apex from the step back technique. And this recommendation for rising rotary files by the company to use a crown down technique on these files. The crown down technique will give you less debris extrusion. Another cause of pain is the chemical factor, which is the irrigation. Anytime the irrigation will go out beyond your apex, whatever sodium, I'm not talking on sodium hypochlorite accident. I'm talking about the chemical going beyond the apex, even minimally, will cause a post-operative pain, a post-operative irritation. And the third thing is the instrument control. And for the irrigation control, how not to have extrusion of the chemical beyond the apex by using a thin gauge sided vented needle. And the third cause, which is the instrument control, mechanical control, we go back to the most important thing, which is the working length. As long as you are working and strict faithfully to your working length, you will have very minimal post-operative pain. So always strict faithfully every time to your working length. You have to respect your working length so you can not go beyond the apex and making the pain more suffer to your patient. The fourth cause of the post-operative pain is it the sealer itself. Sealer is a foreign body. Anytime the sealer going beyond the apex, especially in vital teeth, the patient will also suffer from post-operative pain. It's impossible to have a zero post-operative pain, but we want to try to make it very minimum post-operative pain. This is the three main reasons why patients have post-operative pain. This is one of my cases. We have a broken instrument in the 𝗬𝗀𝗶𝗱𝗲 canal. How we could reach our apex safely. First of all, we read the case very carefully. We watch carefully for any broken instrument, the prognosis of the tooth, how many appointments do we need. We inform the patient about the whole treatment plan, and we started by cleaning the 3 canals and leaving the broken instrument for the final. After this, we retrieve the broken instrument from the 𝗬𝗀𝗶𝗱𝗲 canal. But first, I filled the 3 canals. Why? Because I don't want the broken file to jump inside other canal. Okay, and then we have the manual file to reach our apex, and this is the final results. Thank you, everyone. I hope you enjoyed the presentation and my experience with the Fanta rising rotary files. This is my QR for my Instagram if you want to watch more cases. And thank you, everyone. Thank you, Amy.
Thank you, Dr. Suhaib, and thank you for giving us the wonderful course. And thank you all for the participants. And I see some dentists, they said they will try the rising file right now. Thank you so much.
Welcome.
Yes. And if you have any questions, you can directly message to Dr. Suhaib, and also you can direct message to Fanta Dental. So thank you so much for today's course.
Thank you, Amy. I'm very, very honored to be part of the Fanta company for unlimited and always support with the newest files and materials in the market. Thank you so much.
Thank you. Okay, see you next time.
Thank you.